Good afternoon. I think we should start. So our session today is dedicated to one-stent bifurcation techniques and possible bailout situations using multimodality imaging, and cooperation between European Bifurcation Club, Visible Heart Lab, and Medtronic was initiated in 2012. So for the last 8 years, we try to work together because there is a need to create educational programs for fellows, young interventional cardiologists, aiming to help understanding bifurcation treatment techniques, complications, as well as outcomes. And the idea is to prepare and record at the Visible Heart Lab series of case scenarios where trainee can learn step-by-step performance of different bifurcation stenting technique and based on combination of imaging technologies and computer simulation. And most of us had privilege to attend one of those courses at the Minneapolis. And you see on this picture Francesco Burzotta and Jens Lassen working very passionately, like in a real life. I can imagine they are so focused. So they will try to explain how to perform optimization of provisional one-stent bifurcation PCI technique and possible bailouts using Visible Heart Lab videos and simultaneous OCT recording. You will love it very much because seeing is believing, but now it's not just seeing with angioscopy. You have the latest software for OCT analysis, and in the next 45 minutes, Francesco will speak about provisional technique, T and TAP, with visible heart imaging and OCT. Jens will speak about Culotte technique, but provisional Culotte again, and post-procedure flow simulations will be done by Yanis Chatzizisis. So I'm sure you will enjoy next 45 minutes, and I would like to invite Francesco Burzotta to present provisional.
Okay, so I will start by trying to let you understand what can be the next step for the visible art. So, I mean, the presentation by Paul was outstanding. This is an incredible environment in which we may learn. And there is also the potential to try to figure out how this information that we learn can be transferred to other colleagues. So when you go inside, it is very nice. You see with different eyes when you come back. But can we check what we are doing like we do in our practice in the cath lab? So we perform in this lab the procedures according to angiographic guidance, which is like we do, but it is also important to understand if what we saw in additional way by the visible art can be also found in our daily practice. And in doing this, I think that the European Bifurcation Club did the selection. So we think that 3D reconstruction performed by OCT is so nice that allows the interventionist to really have another stage of compression of what we are doing inside the coronary arteries of our patients. So what we did? Simply, we started discussing with the people that could help doing it, and the two people are the Chuck from Medtronic and Paul from the Visible Art, because they are the one that may facilitate the occurrence. I think that it took a few seconds to convince Paul. It took long months to convince Chuck. And at the end, we have been able to plan the start of this OCT experience inside the Visible Art that was never done before. To do this, what happened is the fact that we had to a long flight to go from Europe to Minneapolis. And after that, we had to work hardly. So it was really what we did. And the result is the one that I will show you for the first time here this afternoon. So this is OCT inside the visible heart. So the heart is beating. You have the OCT recording over there. In the left top panel, you see that there is the probe of the OCT, which is very clearly seen. So this can be done repeatedly. It can be done without contrast because, as you probably know, we perform a contrast injection inside the heart of the patients because there is the blood. Over there is a saline solution that is really transparent. So you have these high-quality images by OCT without the need of adding the contrast. And what we did is to acquire it at all the stage, having always very high quality OCT images. And then we enter inside the bifurcation. And what we do is to perform OCT routinely. This is what is at the bifurcations that we were going to image with the OCT. And on the top you have the long axis reconstruction. But when you enter the last cutting edge 3D reconstruction of the OCT machine, you have this visualization. So really, I think that we are ready to enter into the coronary arteries of our patients during our procedures using OCT 3D reconstruction, and they are really close to what happens inside the visible heart. So what we did once more was to test the goodness, the appropriateness of the provisional T-tap as according to the EBC recommendation. The first step, as you know, is crossover stenting with the stent sized 1:1 according to the distality, and this is the pullback. So with the stent optimization software, you may see that you have your stent, which is really very, very well recognized. I mean, you may recognize the type of stent, where are the links, and so on. With the OCT machine, you have also the possibility to have immediate the lumen reconstruction, allowing you to understand what is the lumen obstruction, if there is. For sure, in this situation, there was not. And this is how the bifurcation appears when you perform crossover stenting. We already showed in the past, and this is how you see the side branch ostium with 3D reconstruction with the stent struts floating in front of the side branch. So all of this is nice. I think that once more you demonstrate how close are the 3D reconstruction we are able today to do to what happens inside the coronary arteries of the patients. But what is good is also the fact that we are now having tools that allow us to perform automatic analysis of what we are doing. So in the top level, you have here the lumen reconstruction, but with just one click, you may analyze also the apposition. And when you perform crossover stenting, you have always, according with the ABC recommendation, so 1:1 to the distality, you have a huge malapposition into the proximal part of the stent. So here the stent seems okay, like happens inside the angiography. So it is just a matter of applying the stent optimization apposition analysis, and you will see in a moment that the struts will color in yellow if they are malapposed more than 200 microns, and if in the case they become red, they are more than 300 microns. And so if we apply this, you see here that you have a lot of red and yellow areas. And when you look at the area of proximal to the bifurcation, you see that it is always and all over red. So there are all cross-section with the malapposed struts that are so far from the vessel wall. And since we like also to understand by 3 dimension, you see here. So this is the proximal part, and you see that there are almost really few white struts. All the other part is hugely malapposed. All of these may be the start of complications in the case you go on with the rewiring. So on top of this selection, so 1-to-1 according to the distality, is really important to correct as soon as possible by POT, having a balloon which is appropriately sized to the proximal main vessel. This is the result after POT inside the divisible art, and you see that there is no malapposition apparent. This is the reconstruction, and here the stent became all white, and you see here the line that shows you that it is all well opposed. So this is really fantastic, and here the stent become all white, and you see very well that you have a perfect result for our stent in this condition. We studied in the past here at EBC main all the advantages of POT, and one other effect of POT is the fact that it changes the geometry of the stent struts toward the side branch ostium. So this is the reconstruction done in the same experiment in the visible art. This is before POT. You see that there are all these floating struts here, and after POT you have this situation. So there is not only the correction here, but there is also this opening of the stent struts that is really, impressive, and is something that can be in our mind, because I think that when we have a properly done POT in a relatively small side branch, it is really almost impossible to have better results with the kissing balloon inflation and so on. So this is very important, and the other point is how good can be the possibility to rewire in this situation in the case of need, how easy can be the possibility to advance a balloon toward or a stent. So all of this makes sense, and all these images have been done with a software that can be found in our CAT lab every day. So it is something that really deserves attention in my mind. Then what we performed was distal rewiring and kissing balloon inflation. I don't want to bore you with all the steps which are required, we already shown. This is the result we had. For sure, what we take care was to have a balloon which was not so long. So you see that here there is no measure oval shape deformation. You see that there is no other red or yellow color that comes out. So in this case, the selection of the balloon was appropriate not to jeopardize the results of the provisional with POT inside the main vessel. And this is the side effect of kissing balloon inflation we are looking at and we are looking for when we perform. So you see that there is perfect patency of the side branch into the visible art, but we want to know if in our patients we may check, and we may check. You see very well that you have a fantastic access to the side branch. There is virtually no residual stent struts inside this bifurcation ostium. After that, you may go on with, in the case of need, with the T-stenting or TAP. I mean, we have a lot of discussion about what is the best. For sure, I mean, the best TAP stenting is the one in which you have node protrusion. This means that you end up with a T-stenting. The problem is that it is not always easy in doing, and even if you aim at performing a T-stenting, it makes sense to let your balloon be prepared inside the main vessel to be 100% sure that you will perform kissing balloon inflation after that. So we performed our procedure according to the angiographic guidance, and there was some protrusion. So you see here that there are some stent struts here, but also you see how patent, is the access to both the main vessel and the side branch. What we paid for with this technique was these stent struts of neocarina, which was just the result of the fact that we didn't want to miss the possibility to cover all the bifurcation area. And then you have the 3D reconstruction. You see here that there are limitations with 3D, even with the last cutting edge, because it is evident that we may capture here the neocarina. You may see it. It is not so long, but it does exist, and you capture. The problem is that the automatic machine algorithm to allocate the stent and recognize the stent struts starts doing errors because the geometry of the stents is not recognized. So there are limitations when you go with, a very complex technique. Sometimes you are not able to have these fantastic images I showed you, but all the steps I showed you up to the kissing balloon inflation can be really confirmed in the case of DUB, during our procedures, during our clinical practice. So just to finish, I should thank all the Visible Art team. It is always a pleasure to be there, and when you go, you feel part of them. It is also related with the fact that they give you a cup of the Visible Art that tells that you are part of them. And as a final remark, I want to personally thank Thomas Valenzuela, that was the one who was mostly taking care about the image processing, visiting my lab after the Visible Art experience. Thank you for your attention.
Thank you, Francesco. I think you can stay there, and if we get some questions. What else would you like to see? Yeah, please, can we have a microphone? Images are really so fascinating. It's unbelievable for education, maybe not for this audience here, it's confirmatory. But for PCR or TCT, this kind of presentation is really seeing is believing. When you see this one, you really understand why 3 diameters. Please.
Hi, Suresh Vijayan, Bombay, India. Excellent presentation, and I think mind-blowing pictures, really. My only question is, would you actually take the trouble of going down the side branch with the OCT to look at what's the side branch doing? You implanted the stent, you can see this carina, which has got a slightly higher metal load, but how does it look from the side branch side versus just the main branch?
So we collected around 200 3D reconstruction for each experiment we did. So I selected the most informative, to let you understand. What is good with the 3D reconstruction is the fact that you may use the different tools, you may have fly-through, you may change the bifurcation. So as soon as you enter inside the interaction with the machine, you may really look at with the perspective you like more. For sure, it is possible to do like you anticipated. Sometimes you miss, the deepest part of the side branch. There is the problem of penetration of the optical, probe. So sometimes when you have big side branches, you have shadow at the end. So you just see, the true ostium, and then you do not get, the profundity.
Okay, thanks, Francesco. I think we should proceed with Jens and Culotte.
One minute. Is it the hardware is just different from OCT machine, routine OCT machine?
So this is the last release of OCT. Yeah. So it is just a matter of last software. The acquisition modality is the standard one. What is different to have this 3D reconstruction is the fact that the machine should have the most updated but commercial software.
Okay, Jens, please.
Thank you very much, and thank you very much to Medtronic to make this possible. But most of all, do we have my slides? We do have my slides. Thank you very much to Visible Heart Institute, and I think you make a very, very good presentation of how fantastic it is, Francesco. There are a lot of very, very dedicated people there who make this possible. So you have seen what we could have accomplished of that day, which was really hard work, and there was many, many OCT runs, and there was many, many, many stenting techniques. Now, I will try to run through some of the philosophy behind the stenting techniques we use, trying to go to the core of the EBC, and just show you how stepwise, using these modalities from Visible Heart Lab and what we acquired that day, we actually ended up in having a clear-cut view on how we see provisional stenting in the EBC. So, yeah, well, I think I'll use this one. These are the operators. You have seen this picture. And there we have the provisional stenting strategy. So, again, you can see what you do. You can see that the wire was not actually really as we think they are. They are twisted already. We can't see that very clearly in angio, but maybe we have appreciation of it in the right panel. But you can see exactly what we do. And as Francesco told, we were just putting in the stent with respect to the distal diameter and keeping the proximal part floating. And then, if we look into it, there we have the bifurcation, and there we have the takeoff. I guess it's basically the same that we saw from Francesco. So we have now a stent put in the vessel, crossing the side branch, floating in the proximal part, but partly well opposed in the distal part. And that's where we are. But we have to continue to treat this lesion. So remember here, first thing is, if you lose your wire in this step, it would be very, very difficult to come back. So next step is actually, of course, as you know, the POT. So what we are doing now is actually scaffolding the main vessel, slightly, quiet, and precise, in the way that we have depicted so many times in the consensus documents from the EBC. Then we do the POT, which is the proximal optimization, placing the balloon with respect to the carina, a bit retracted from the carina, and then a dilatation. And after that, an OCT run. And again, it's possible to see how nicely the stent is opposed in the distal part and how chaotic it looks in the proximal part. And if we go here, we can see the floating struts across, the takeoff of the side branch, and we can see that there's huge malapposition in the proximal area, not surprisingly, because the vessels are tapered. And again, in more details and from more distance from the same run, the reconstruction. And again, as you can see, Thomas went over to Francesco in Rome and made a huge amount of work with Francesco to make this picture available for this session. And as you can see here, the next step is actually to go down and find the right place to cross. This is actually depicted here. And what we're trying to do is follow the guide, try to see it. And here we see in real life what we did. So we crossed distally and we dilated. And after that, we kissed again. And this time, we actually tend to kiss as deep as possible with short balloons to avoid getting too high up in the proximal part. Simultaneously kissing we don't do anymore. Segmental, first one balloon, low pressure, then second balloon, low pressure, then down, basically at the same time as fast as possible, because the thing we do here is actually taking care of the carina and putting it in the middle. Having done that, we do a repot, but then we retract the pot balloon a bit more, not try to avoid the metal carina. It's not that necessary now, but in the tap procedure that Francesco just showed, it's very easy actually to push the metal carina back where it came from if you go too deep. You know these things, I guess, all of you, but what is interesting is actually here we see it, and the tutorial effect of this instrument and what we have acquired is enormous. This is actually what we are aiming at when we are doing a provisional one-stent technique. Stop here if needed. If not, it's possible to continue. And now is the total clue of this presentation, because what is actually to be done if we need a second stent? Yeah, it is to put in a second stent. And we have written lots of papers, a lot of consensus documents, and a lot of everything on how, when, why to do it. But basically, down to the core, it's just to put in the second stent, and everything depends on how deep you put it. Here, it's a T, there, it's a tap, and up here, it's a culotte. Okay, this takes, of course, that you need exactly where to put the stent, which is difficult. So, the illusion of the different names is, the different names are illusion. You don't really know where you end up. But one thing you know, if you go too deep, you'll miss the coverage here. If you go too high, you have a metal carina. And if you go up here, you'll cover everything, but you'll have a double layer. So these are the pitfalls. The steps to continue with the culotte is very intuitively down with the stent. Comes here. Try to put it in. You can make a mini culotte, have it go deep, but not so deep that you are not able to cross without crushing. You can let it go high if you need extra scaffolding in the proximal part. But anyway, put it in, recross it, kiss it, coming here, the kissing balloon. Again, low pressure, small balloons, close to the carina. And then look what happens. Yeah, we have actually a quite nice result. The vessel is opened, there's a good apposition, there's some floating struts in the proximal part, maybe due to the manipulation during the procedure. We see it very clearly here. So, final pot to correct the proximal problems. And again, here we see again what we can accomplish just with the OCT apparatus in the lab. You will acknowledge the double stent layer in this area, but you will also acknowledge that it's very, very well opposed and that the configuration of the stent is exactly like we would like to have it. You're not able to see actually the side branch in this pullback, but nevertheless, you can see it from the top, appreciate the carina. And here, actually, we have the philosophy behind. Keep it simple, put in one stent. If you need a stent more, put it in. And depending on how deep it is, it could be a T, tap, or a culotte. This was a culotte. And if you would like to go deeper into these pictures made at the Visible Heart, they are available from the Medtronic website with this address. You'll have it later, or you can have it from the booth, or you can go into Visible Heart Institute's tutorial homepage, which is a fantastic source of endless information. So if you go in there, take care. It will take hours before you come out. And again, thanks to all of you that really participated in this and made it possible. And this is the final thing. This is actually the case I've shown with the Visible Heart technique, with the OCT, and now also with the micro-CT. You will imagine when it turns that you can see the same picture of the proximal double layer of stent that you saw in the OCT pictures, and you could imagine in the Visible Heart. So this is actually what is possible to do, and it has increased our learnings about stent techniques tremendously. Thank you very much for your attention.
Really fantastic images again. Before going further to questions, you know what surprises me? We have such high quality educational material now, but when I listened this morning to Bernard Chevalier's presentation of one of the largest and the latest registries of what we do in the practice, 36% of people do POT. You know, if you see this terrible under-deployment in the proximal part and all the complications that we face, what is possible explanation? How can we proceed to correct?
Well, we need to do a lot of teaching and we need to have a lot of meetings. But I think actually what happens is when you have the X-ray imaging and the normal angio guiding, you are not able to see these things. So you have a perception in your head, what is happening? it could be wrong. But you think what's happened because the final result is nice, and you won't see the stenting, the floating struts, and you won't see all these things. So one thing could be to apply much more imaging while doing this. And it's, of course, the way forward. It's not cheap. It's costly. And in huge areas of the world, they don't have the economy to that. But at least when you're teaching and when you're trying to understand, it's a very good thing to use imaging, because then you learn, and then you see, and then you imagine all the mistakes you're able to do. So again, more education, and I think much more of these kind of things. Try to visualize what the problems actually is.
Thank you very much, Jens. The last presentation is by Ioannis, post-procedure flow simulations. While you are preparing, Paul promised to me to give me this kind of possibility to use 3D glasses and help people fly through this 3D. So at PCR next year, you will see everybody with 3D glasses at all bifurcation session. Thank you, Paul.
Thank you, Goran. Thank you, everybody, for including me in this beautiful session. Hello. So I modified slightly the title. Here we're going to put together the visible heart lab with computational simulations. And this is going to be the foundation, the basis to allow us to perform flow dynamics in the stent bifurcations. That's a collaboration with the Visible Heart Lab. So, my disclosures. So the key word here is mixed reality. We have different viewpoints of bifurcation stenting. We can apply in vitro bench stenting simulations using silicon models. We can have the beautiful facility of the Visible Heart Lab for ex vivo using porcine heart stenting simulations. And then we can also consider computational stenting simulations, which run entirely in computers. And coming to the computational platform that we developed, this is the workflow here. We have the anatomy, which is a combination of angio and any invasive or non-invasive intracoronary imaging. We apply wall mechanical properties, which are realistic. Then stenting part, which uses realistic stent design and properties. Then everything runs computationally. The stenting runs in a computational simulation fashion. And then finally, the outcome is biomechanics, flow and solid mechanics, and also stent morphometry, expansion, apposition, and so on. Let's start with an example. This is a tap. This is directly to the philosophy of this club with a provisional one-stent approach. So this is an in vitro bench case that we have a main vessel standing first with an integrity 3.5 there. On the right side, you see the in vitro, so this runs in the bench, and then we replicated the same thing using the same geometry, the same stents, balloons, computationally. That's the side branch opening of the ostium, of the struts. Then we have delivery of it's a bailout, it's a tap, so we have a delivery of the side branch stent here on the side branch with a little bit of protrusion into the main vessel and the balloon of the main vessel in place. And then finally, the kissing balloon inflation here to create the neocarina and restore everything. And that's it. Also, this is the foundation for a fly-through, so we can fly through. You see here the deployment of the side branch stent, and then now there's an invisible balloon that with the kissing creates the neocarina. So that's how the neocarina looks from the inside. Here we have the micro-CT of the actual case, and that's the simulation. And they're pretty comparable in terms of MLD. And those are serial cross-sections across the real case and across the simulated case. This is the tap area with the neocarina within the main vessel, just proximal to the carina. and pretty comparable position of the stent in reality and in the simulation. Even this malposition there can be replicated with the simulation. And flow dynamics with the velocity profile and the shear stress, pretty smooth flow domain. Then we we went from the bench computational simulation to the ex vivo computational simulation approach. We had to fly a shorter route compared to Francesco, just from Nebraska to Minnesota. We got into the visible heart lab and we did some cases. So here we have a T stent with the first stent deployed into the OM. It's an Onyx 225 and also computationally. Then the main vessel stent, a 275 Onyx. Then the pot, another pot, and final result with good coverage of the carina. And this is not expected here. I need some help maybe.
Can we have a technician? Ben, can we have a technician now? Maybe it was too deep.
And it got angry. It got angry. It got angry. Yes. Yes. Can we go back to the workflow? So I have a provisional there, another case, but I can't show this. Let's try, please, guys. It's a nice case. I don't have it here. So.
Is it this one?
No. No.
It's not here.
No, it's not here. Okay. Anyway, so that was another case of provisional in the LED diagonal, coupling the real case in the visible heart lab with a computational simulation. So take-home messages here is that we have different viewpoints of bifurcation stenting, the so-called mixed reality, with bench approach, ex vivo, and computational simulations. Computational stenting simulations are quite accurate and feasible. It's an approach that can replicate the stenting procedures that can give us information about stenting techniques and designs. And the message here, it's clear that always we should consider provisional, one stent, bifurcation stenting technique. That's a philosophy with bailout conversion to either T or TAP or Culotte as needed. I would like to thank my invaluable group, my engineers, doctors, biologists there, multiple collaborators across the US and the world. Yes, thank you, that's the TAP. So this is an LED diagonal. So we deploy the stent in the LED first, and then we perform, that's the stent in the LED. So we took the same anatomy using OCT on both branches. We reconstructed reliably the anatomy of this particular bifurcation, and then using realistic stents, we deployed the stents computationally in a realistic fashion. And then we performed POT in the visible heart lab, and we replicated the same POT approach computationally. And you see here the stent, the final result in the LED. That's the POT side here with the flow dynamics with pulsatile flow. And I was about to conclude that it's a philosophy that provisional one-stent technique should be our top priority with bailout conversion to tier TAP. So I was about to thank multiple people here, the EBC, definitely the Visible Heart Lab. Paul, thank you for having us in your beautiful facility. My great collaborators in Milano, the IXL facility in University of Nebraska, the Japanese colleagues, and of course, invaluable help here from Medtronic. Thank you.
Thank you very much, Ioannis. Any questions for Dr. Chatzizisis or any of us?
Thank you for a beautiful presentation. I'm most struck visually by your simulation of the stent expansion and then subsequent recoil.
Yeah.
So what's driving that simulation of recoil? Is it just simply the sizing of the vessel, or you alluded yesterday to making maybe some further assessment from OCT in terms of tissue characteristics that might impact on that as well?
Yes. I think, thank you, that's a very key point here, that recoil, as Tim Makeley said previously, is happening with every metal. And that's something that we should always take into account. And recoil of the stent is dependent on two factors: on the stent material itself and the radial strength, essentially, which is dependent on the design and the metallic properties, and also to the tissue. So both should be considered. It's different recoil when you expand the same stent within a very stiff calcified vessel versus a very lipid-rich vessel.
But in that example that you gave, which is in a porcine, healthy vessel,
exactly,
you're demonstrating non-uniform recoil. So it wasn't that the whole stent comes in. There seem to be areas that recoil more than others. So what's driving that simulation on those healthy examples?
So here we apply normal, healthy porcine arterial wall properties, and the recoil is uniform. I'm not quite sure that I agree with you here. That it's
so visually it looks like there are certain areas that recoil more than others.
It's you know, I don't think so.
Okay.
I mean, we can check it back, but I don't think so.
Yeah. Okay. Thierry, sorry. I was sure that you will ask about.
No, I think there is apparently non-uniform recoil, just because you have a proximal part of the vessel, a distal part. So proximal part is larger, so you have less recoil, just because of that. Now, I just want to ask you, because there is a lot of confusion between T, systematic T, and provisional T. It's completely different. One is strongly recommended by EBC, and the other one is not recommended. So can you explain that? Because I heard a lot of confusion about that.
Yeah. Thank you, Thierry.
Unfortunately, we have not paperboard, but you can do with your hands.
Yeah, I can try with hands. So for a long time we are discussing main vessel first or side branch first, and what we would like to have, what we don't like to have. And I think now we have a very nice material from visible heart and from OCT to base our decisions on what we exactly see and measure. What we try to prevent at the level that is possible and feasible is overlap of the metal, which is potentially unnecessary. Idea of the EBC is to try to promote optimal optimization proximally with POT, then distal recrossing. By going distal, you actually scaffold partially the ostium of the side branch, and having that protrusion of the metal, you actually decrease the amount of protrusion of the second stent inside the main vessel. And it's long-lasting discussion and dilemma. We try to convince and to convey the message that T and TAP are actually the same. It's just how much you pull back your stent, and you should try not to put it unless it's really necessary. And it's really necessary if you cross proximally or if you have very narrow angle. In narrow angle, in order to cover the roof, you really need to protrude. But even in that situation, advice is to use stent enhancement software and try to really be as precise as possible. So TAP is variation of T, trying to limit protrusion, and Culotte is just in case that you have adequate anatomical condition and you want to have full coverage proximally, then you pull it more and try to do mini Culotte. Was that enough? Systematic T, yeah. So from the very beginning, we tried to avoid starting stenting the side branch first, because you have actually sort of crash stenting applied in that case, and we try to avoid it. So systematic T is not something that remained in our new meds classification. We excluded that one, and of course, this is something that we can discuss more in the further sessions. So for now on, I really would like just to conclude. Can I have my conclusion slides, because different slides are here? Just one slide, actually, to thank Medtronic and to thank Paul and all the team from. Yeah, I don't have my presentation. So I really would like to thank all of the people from Medtronic who helped us get the connection with the visible heart and to create together this fascinating material for teaching purposes. And I really enjoyed a lot this session, because now we are going step beyond. It's not just visible heart. Now we connect with OCT, so we come closer to real clinical setting. And it's just discussion, should we do it at the same time? And when we teach at big meetings, should we show simultaneously OCT and visible heart, or we should go from one to the other and then probably add also micro CT and 3D printing with virtual reality? Because I think these are all directions with improvement in technology that in the future we will teach our younger colleagues who are now fellows how to optimally perform procedure. And this is really necessary, because if you see the data, it's really unbelievable that in 2018, only 1/3 of bifurcation stenting is finished with POT. So 2/3 of procedure, you don't even do POT. You go crossover stent and have coffee with your team outside the lab. So I think these images are convincing enough that we have to proceed and at least perform POT. So I thank you very much again for attending this session, and I like to invite people for the next session, parallel session summary. Thanks, and enjoy the rest of the meeting.
So, dear colleagues, we continue now with a summary of parallel session from yesterday, and we start now with bench and computational bifurcation stent simulation from Dr. Dubini.
Chairman, good afternoon, everybody. And I'm here to give a summary of the session about bench and computational bifurcation and simulations. Yesterday, we had a total of 8 presentations. I roughly classified them, roughly, 3 on computational methods, 4 were in vitro studies, as 1 was a nicely combined study in vitro and numerical. The first presentation was by Dr. Samadi, and he asked a very important, very challenging question. Let's say, are bifurcation stenting simulations needed? He went through a number of issues related to the stenting of the coronary bifurcations, moving from the the current status of the outcomes, which are not optimal, mentioning the fact that we have a lot of micro-CT studies, in vitro studies. We have the impact, the effect of, let's say, the local geometry, the three-dimensional geometry of the connection. And we have the fact that numerical simulations are really complex. And just to give you an idea, I showed this chart just summarizing the workflow to obtain numerical simulations results starting from clinical imaging. And he also mentioned the fact that we have some prospective studies underway to see exactly this, the potentiality of this method. Luckily for me, as an engineer, his answer was yes. We still need we need numerical simulations for stenting bifurcation. The second presentation by Dr. Iwasaki was an in vitro study. He was interested in investigate the local flow disturbances in the vicinity of the struts, comparing different technique to complete the procedures, pot without kissing balloon and pot with kissing balloon. And he wanted to investigate the influence of stent size selection according to the proximal size of the vessel. This is just an example. He used the micro PIV system. Velocimetry is an experimental procedure approach to see the velocity. It was very nice to see how the effect of the geometry affected the peak velocity in the side branch, which means also the strain rate and the washer stress. And he concluded that POT and KBT are necessary to reduce the incomplete position of the stent struts. The third presentation by Dr. Ikichi was again an in vitro study. He was looking at the effect of the stent position in using a technique based on micro-CT. And it was very interesting because it showed results in terms of the, let's say, incomplete positions looking from the side branch and from the main branch. This is just an example of the results, and it was possible to see how in the different configuration with the different geometry and with the different pressure in the balloon, the results were quite different. His conclusion was that, again, also for this problem, a proper and appropriate choice of the stent is important to reduce the effect of the malposition of the struts. Another in vitro study was presented by Dr. Kume, and he used the videoscope technique, and basically was looking at the effect of the length of the balloon in the main branch. And these are just some example of the some examples of the experiments that he did. You can see with the yellow color the effect of the let's say the jade struts in the ostium, and how they change according to the technique he proposed, the proximal balloon edge dilatation, in comparison with the conventional technique, let's say, which is the lower row. His conclusion was that the report is excellent for this this type of bifurcations, and especially the choice of the technique of the proximal balloon edge dilatation can be of help for this problem. The study by Dr. Paradis was a combination, as I said, of numerical simulations and in vitro tests. And she wanted to compare decay crash versus TAP technique. And the evaluation was aimed at looking at the different strata position and the thrombus formation in vitro models and by numerical simulations. In vitro models were measured with OCT, while computational simulations compare the effect of the fluid dynamics in terms of washer stress and velocity profiles in the bifurcations. The conclusions were that not much difference can be found in the two configurations from looking at this technology, using these technologies, except for the fact that POT significantly reduces the eccentricity index of the expansion. Another interesting result was the fact that these procedures, let's say, using numerical simulations allowed them also to see that malapposition also occurs in silico based on the numerical simulations. So it's something coming from the mechanics of the stent deployment. Todd presented another work based on in vitro study, and he wanted to see the effect of the kissing on the culotte. These are the geometries he examined. This is an example of the results in terms of changes in the procedure, and these are the time for rewiring and the total time for the procedure. And his conclusion were the double kissing approach can actually optimize the culotte technique. The effect with the DK culotte can be even superior, not only to the culotte, but also to the DK crash technique. Clinical validation still to be completed, to be done. Claudio Chiastrad presented the numerical approach, the numerical workflow, which is we have set up at Politecnico di Milano, and spent some time investigating the effect of possible uncertainties in the results. Can be due in numerical simulations to the fact that we have unknown boundary conditions, can be related to the fact that OCT reconstruction has a degree of freedom that can affect the success of the reconstruction of the stent, and can be due also to the fact that the number of angiographic frames used to evaluate, to assess the flow has also an impact which is qualitatively cannot be seen, but quantitatively exists. Last presentation by Yannis Chatzizisis was related to the fact, his approach to the bifurcation atlas. This is an approach that also exploit the effect, the consequences of the use of big data technologies to extract information from that, from all this, the information we have using artificial intelligence technique, and concluded with a call, advocates a call by the EBC to collect as much as possible information, quantitative information on stents, stenting bifurcations. Thank you for your attention.
Okay, thank you for a very nice summary. Any questions? Not clear, so we are very happy to have this data and information to implement this data in our daily routine.
Okay, next speak bifurcation and drug eluting balloons. Girasis, please.
Good afternoon, ladies and gentlemen, dear Chairman. It's always a pleasure, privilege to be here, and I would like to thank the organization for inviting me yet another time. Could someone put up my slides? Okay. I'll try to summarize the parallel session on bifurcation and drug eluting balloons. I have no disclosures. The three first talks were rather review talks on current status and relevant literature. To start with Dr. Privulovic, to copy his own words, what is the status of the DEB right now? I use DEB when I feel that stent is not the best choice. DEB is not on the shelves as an adjunctive and complementary tool, not to replace stents. What constitutes an ideal balloon? A low transit time, a deliverable, trackable, crossable disease balloon, drug of our choice, I'm going to come back to that, and a drug carrier, which is the most critical key to the design of the device, featuring all these elements. There is currently a number of available coronary paclitaxel drug-coated balloons, which, however, show no class effect among them, so there has to be another factor to account for the difference in clinical performance, which is the improvement in the drug carrier, as evidenced, for example, by the huge difference in late lumen loss between Culotte and Culotte 2 with improved technology resulting in better pharmacokinetics and better late lumen loss. To come back on the drug issue, Limus, although it is considered the drug of choice for coronary deaths, it was not the case for DEB until recently due to decreased lipophilicity and very hard coating. There have been some advancements, to name but a few. The Magic Touch shows an excipient that results in better lipophilicity, whereas the solution shows microreservoirs out of biodegradable polymer intermixed with sirolimus and a novel cell-adherent technology. Dr. Araya gave a talk on drug-coated balloons and coronary bifurcation treatment, first stating, as it is the fact, that neither the European guidelines on myocardial revascularization nor our own consensus last year show any endorsements on the use of DCBs in bifurcation treatment. There have been roughly 4 strategies tested: DEBs with bare metal stents, DEBs with the use of DES in the main vessel, DCB-only strategy, and DCB in bifurcation restenosis, which was also negotiated by the next speaker. As a matter of fact, the first strategy was proven not to work, although the situation in Babylon with improved DEB gave similar results for the side branch. The situation was completely different when using the DES, either the Taxus or the Desai DES together with a DEB in the side branch, which proved to be a safe and effective treatment option. The DEB-only strategy was proven both by the Schultz study to work in de novo bifurcation lesions. Actually, 33% of them were de novo left main bifurcation lesions, but also by the PETCAD-BIF randomized trial to be again, which was done in Medina type 0XX cases, which was proven again a feasible and safe therapy. When it comes to the ostium of the side branch, the answer comes from the Megali meta-analysis, which comprised 4 studies, 3 RCTs, and a debut, which, although not conveying a clear message, resulted in a lower, statistically significant, lower side branch late lumen loss. Dr. Alfonso expanded on the perks of DEBs for in-stent restenosis, deriving data from the vast array of RIBS trials, either if it has to do with bare metal ISR or DES ISR, or the comparison of DEB versus usual balloons in the RIBS trials, and all of this data was implemented in the Daedalus big meta-analysis comprising 10 randomized trials, which showed improved, but marginally improved efficacy for DES compared to DEB, but similar safety profile. This all translated into 1A recommendations for both DES and DEB regarding the treatment of in-stent restenosis. Coming back to the issue of drug-eluting balloons in restenosis of bifurcation treatment, which was negotiated by the last 2 presenters, there were good results actually recorded with DEB in the first bifurcation restenosis, coming as far as copying Dr. Harada, which is the sole similar publication, relevant publication for the time being, showing that in 2-stent bifurcation ISR, the use of DEB is satisfactory, coming even to the point that it's feasible to use DEB for left main bifurcation ISR. The 4th speaker, Klaus Bonaventura, showed us, detailed us results according to the vessel diameter where they are used. He detailed and presented step by step the German consensus algorithm regarding the use of DEB and showed us some beautiful cases. Actually, from studies such as Basket Small or Bello or Piccoletto, DEB were proven to be not only inferior but actually superior when it comes to the late lumen loss regarding the treatment of small vessels in diameter smaller than 2.8 millimeters. Since, however, the drug-coated balloon allows for local drug delivery and endovascular therapy, optimal lesion preparation is mandatory for drug-coated balloon, and this was stressed and evidenced by the results of ISAR Desire 4, where an angioscope balloon was used before the use of the DEB. He detailed, as I told you, the step-by-step German consensus algorithm, which is, there's no point in detailing that right now. And he succeeded that to achieve, it is of utmost importance to use the DEB first and then stent the main branch in order to avoid any damage of the drug coating on the DEB by crossing stent straps. On the other hand, kissing DEB, according to the Potsdam experience, seems not to be a very good idea. Still, according to all of the speakers, actually, and this is the message that was conveyed from the session, we are missing the bifurcation study. That is the fifth speaker, Juan Luis Gutierrez Chico, came up with several scenarios for future studies, detailing a first scenario, a Nordic 3-like, like he called it, where he hypothesized, it could be hypothesized that in true bifurcations with meaningful side branch, DEB FKB would be better than provisional stenting without FKB. A second scenario for complex lesions, the definition is to be further detailed. Provisional stenting plus DCB FKB might be superior to two stents techniques. A third scenario for report where provisional arguably could be better or worse than DCB report, and some sub-scenarios for report and DOT, all of them incrementally necessitating a larger and larger number of patients to be enrolled. Dr. Rathore concluded the session by instigating a discussion for an upcoming bifurcation DEB trial compiled out of provisional group and the two-stent strategy, and I would love to hear the conclusions of the relevant discussions from him. Thank you for your attention.
I'm coming from the city where Magic Touch is manufactured. And I'm using this in phase 3 and phase 4 trial, and there are small trials we are doing in my institute. Now, we know that in ESC guidelines, instant restenosis is an excellent result, any drug-eluted balloon. Now, the question is that the last discussion, it was that the provisional stenting is the technique of choice nowadays, and two-stent technique when large branch with disease side branch. We are going in one registry, that is bifurcation registry, and that is it is very interesting to know whether side branch to be treated with drug-eluted balloon and main branch with in a provisional stenting. So that could be the one of the main approach. And what do you say about such approach? Provisional stenting with DEB in the side for side branch disease.
I think the entire message conveyed by practically all of the speakers was the initiative of leave nothing behind. It's easier to imagine that would work for provisional plus DEB for side branch. It would be a little bit more tempting, as evidenced and proposed by Dr. Bonaventura, to propose it even for, let alone leave nothing in the vessel whatsoever and treat even difficult and tempting bifurcations without any stent at all. So the first point, the first hallmark, I think it's easy, okay, without saying big words, to reach. The second mark is probably something that we, at least in my opinion, would have to combine with intravascular imaging in order to be able to deliver a result of undoubtedly long-term patency and good angiographic and clinical result.
That's follow-up is required for such type of study. And anybody from audience having question, it's open for audience to ask questions.
I think just a comment on use of drug-coated balloon in a large side branch. We are of the view that maybe in complex bifurcation like 111, where we can compare with two-stent strategy and a provisional with the main vessel stenting, and drug-coated balloon in the side branch possibly could be non-inferior. We don't have that data, but that's the hypothesis. Obviously, there will be some cases where you have to put second stent as a bailout if there is TIMI zero flow or there is a significant extent of disease in the side branch, but that will be limited patients.
Of course, I mean, as in BBC1 and other cases entailing the treatment of complicated lesions, one stent provisional plus DEB in the side branch could be all in a whole a provisional strategy, and of course, in order to ensure that the long-term patency, we could turn up with implanting second stent in the side branch. But I think this will work the same way you described.
Panelists, anybody is having experience of using drug-coated balloon? Okay,
thank you
very nice presentation. Thank you very much. We are going for the third session, and that is by Z. Mehmebegovic, and that is on intraluminal imaging, with the drug, which is the topic of interest nowadays.
Good afternoon, everyone. Dear Chairman, dear colleagues, it's a pleasure to be here with you. I will present you the summary of yesterday's session, which was concerning intravascular imaging. We have 7 presentations. Dr. Amabile wasn't able to present yesterday, but we saw his presentation today. First presentation was from Dr. Murasato. We were exploring balloon and stent sizing in bifurcation lesions. As Dr. Murasato first referred to the EAPCI of expert document published last year for general device sizing, but to be honest, this cutoff values are not really applicable in bifurcation lesions due to its specific anatomy, and these data are not derived from the bifurcation lesions. Choosing the right size of the stent, we can be more aggressive or more conservative. More aggressive means that we can choose it to the EL diameters, or more conservative according to the lumen diameters. And if we choose to be more conservative, we might end up with smaller stent sizes, as is on opinion trial, compared to IVUS guided EL. Then Dr. Murasato referred to us as appropriate size of pot kissing balloons, and they should be selected according to vascular branching law. We are all familiar with Finet law of bifurcations. It's really simple to be calculated and practical, but as Dr. Murasato pointed out, in bifurcation studies, this law using QCA reference diameter was not really fulfilled. As you can see on the right, that the fractional ratio was not achieved. So he advised for obtaining these rules, we need to use intravascular imaging and not angiography, especially for balloon for pot sizing. And the last, we need to optimize our procedure, and we can identify the place where to do that. Using conventional methodology is not sufficient because bifurcation does not have tapering like a normal vessel. It has a step down. So they propose new index called minimal expansion index, which can identify a region where we need to do post-dilatation, and it's much more frequent in the proximal vein vessel than at the area of minimal stent area, most frequently found in the distal main vessel. So these were the take-home messages from the Dr. Murasato. The next speaker was Dr. Gonzalo, with plaque characteristics in bifurcation lesions and how can that affect our strategy making. As we all know, we can use either IVUS or OCT, which can characterize the plaque and the anatomy very well. You can see the corresponding images of both modalities, but the greatest obstacle we can found during the imaging is probably the presence of calcifications, and both modalities are very sensitive to detect them, but OCT has one advantage because in IVUS we have acoustic shadowing. We cannot measure the thickness of the OCT plaque. And why is that important? Because nowadays we have a practical base score for OCT measurement of calcium, which incorporates maximal angle of more than 180 degrees, a maximum thickness of more than 0.5 millimeter, and a long calcified plaque more than 5 millimeters, which can predispose to the stent under expansion, which of course leads to stent failure. So once we identified, we may use some of the treatment modalities we have at hand, and depending on the anatomy also found, we can use rotational atherectomy, orbital atherectomy, or lithotripsy. So also Dr. Gonzalez presented 3 cases, which I will not present you due to the shortage of time, where she used these approaches. And next, we have 3 presentations from the Japanese group of doctors addressing a similar subject, and that is OCT-guided rewiring in crossover stenting. The background for their research was that we can see some overhanging struts over the side branch after crossover stenting, and by choosing the right cell, we can avoid stent deformation and strata position, and also ensure good scaffolding of the side branch. OCT can help us at assessment of the gelling configuration at the side branch ostium, and we have 2 possible solutions, link-free and link-connecting type, which is unfavorable for the procedure. The first talk was from Dr. Nagoshi, and they investigated whether 3D OCT-guided wire recrossing is better than 2D OCT-guided recrossing. And they found that by 3D group, they had 91% rewiring rate. And to be honest, with more rewiring attempts and a longer procedure time, but not more contrast used. Then Dr. Onuma presented the results of the Optimus trial, a randomized trial evaluating online 3-dimensional OFD-guided PCI versus angiography-guided PCI. And their objective was for primary endpoint incomplete stent apposition in bifurcation segments. So this was randomized trial, and at the end they ended up with 55 patients in 3D group and angiography-guided 50 patients. And since this was the imaging session, I need to show you some imaging. And you can see Dr. Unma really well presented what happens when you cross the proximal strut in the angio-guided group, and you can see the overhanging struts on the carina of the side branch. And in the 3D guided group, they use the information they get from the OCT, and you can see the same proximal strut was again obtained, but using the information from the 3D, they were able to guess the distal strut, and you can see the completely out of the way struts at the carina level. So they achieved distal rewiring 100% of the patients, and in primary endpoint, this resulted in significantly less incomplete stent apposition at the bifurcation level, 19 to 27%. And they also concluded that there was unfavorable jailing configuration at the side branch if there is ring at the carina predisposing to incomplete stent apposition. So then one of the chairmen, Professor Ceruz, asked what's the clinical meaning of this information. Next speaker, Dr. Yamawaki, tried to answer to give us some of the answer, and they investigated impact of recrossing and bifurcation angle on incomplete apposition. They also divided the cohorts in link-free and distal, namely optimal, and non-link-free and distal group of the patients. What they did in 105 patients enrolled initially, they did 9-month follow-up in 59 patients with 35 patients in link-free and distal wiring group. And what they found immediately after PCI, optimal rewiring at the point of side branch ostium and at distal main vessel resulted in less ESA. And finally, after 9 months, what happened? Struts at the distal main vessel were now opposed, so that disappeared, but at the side branch ostium, the presence of ESA remained significantly greater in non-optimal rewiring group. to be fortunate, lots of those struts, although unopposed, were covered, so the difference between struts coverage at the side branch ostium was not significant. And the last talk of the day was by Dr. Okamura, who was able to give us some algorithm when to perform imaging to optimize PCI, but he mainly based his talk to his subtitle, Can We Overcome the OCT's Limitations? He referred to the consensus document again, and you can see on the right side that we can use OCT in many of the points during the PCI, and so he focused on limitations on OCT, that is left main ostial imaging and need for contrast to do a proper imaging. So he proposed two innovative approaches how to visualize the ostium on left main properly, and one is using the guide liner with translucent tip. And for us who don't know that available in our cath labs, we can use just some modifications like additional guide wire positioned in the aorta, disengage the guiding, slow pullback of the OCT with injection more than 4 millimeters when the optical lens approaches the tip of the guiding. He also addresses the question of performing OCT using contrast. And on their original data from Japan, he showed us that in 22 Dextran-based OCT guidance procedures for bifurcation PCI, they were able to reduce the contrast dose to 116 millimeters. To illustrate all that, he showed one example of Culotte stenting in left main using contrast and performing 9 OCT pullbacks with contrast volume of less than 100 millimeters. Thank you for your attention.
Okay, thank you. Any questions or comments? Okay, thank you so much. Okay, so we continue now with the next session. Thank you so much.
Okay, so it's time to start. Before the coffee break, we'll have this traditional voting session. I think it's a very important session because we try to answer difficult questions. And maybe there is no answer to these questions. We will see what you think. Okay, so this is the chairs and the panel. We have a very distinguished panel and chair, and this is the 3 questions that we will ask to you. Of course, we'll have a presentation, yes or no. The first one is long-term DAPT after 2 stent techniques. The second one is after crush. If we do a crush, it should be a Deca crush and not a mini crush or traditional crush. And the last one will be about the left main. Should we open systematically the strut toward the side branch or not? We thought that these 3 questions are very important, and we have still a lot of debate about that. So we'll try to answer to this question at the end and maybe make a consensus that will be published for the next paper. So Caroline, if you want to introduce this first discussion.
So the first topic is, after left main stenting with 2 stents, should we prolong DIPT up to 2 years or less? Ah oui, sorry. Yes, the first speaker is Zimarino. Bonjour.
Thank you. I'm flattered for the invitation, but in a very difficult point to defend, but I will struggle for my point, meaning up to 2 years double antiplatelet therapy after double stenting left main. And this is in 92, but in very good shape with abwehr elevation, transient ST elevation in abwehr, and classical 111 left main. That, following the suggestion by Azim Latib, we plan to do with a T stenting. You already commented this. Careful checking, trying to set the proximal stent in the lesion that was mostly long in left circumflex, then with balloon, protection balloon in left main. This was the critical point, trying to have the marker inside the LAD, and afterwards we placed the main vessel stenting at 3.5, kissing balloon. We did an OCT before POT, and we were checking only malposition in left main, but unfortunately, stent was well placed in circumflex, but did not cover the ostium of the circumflex. While the bifurcation itself was patent, also the circumflex was more than 4 millimeters square. Distal LID, proximal LID obviously malapposed. After POT, we had a good stent apposition. Now, checking in literature, there are sparse data on the impact of double antiplatelet therapy duration after PCI on bifurcation. You can see here that data derived from either sub-analysis of studies like DAPT or precise DAPT, or pooled analysis coming from randomized trial like Grandes, or from dedicated registries on bifurcation like COBIS2 or also our ABC registry. I will try to give you an overall view of this. About double antiplatelet therapy, I will try to borrow a word that is very familiar to George, because in the old Washington Hospital Center times he used it a lot. Double antiplatelet therapy for long term is a kind of equalizer when you are not certain, when the complexity of the procedure is increased. And in order to tailor therapy, is all this data go in the same direction, trying to identify the high-risk patient, the high risk of bleeding patient. In that case, you have to titrate lowering the duration of DAPT. But in this case, we can focus on a pooled analysis from 5 Korean registries that takes the name of Grandes, where they analyze 700 left main, about a fifth of them treated with double stenting, where strategy were less than 12 months versus more than 12 months double antiplatelet therapy. And these are the main results. main results show here that double and triple therapy, they used a couple of primary endpoint, an endpoint target lesion failure with cardiac death, target MI and TLR, and a true ischemic endpoint with stent thrombosis instead of TLR. But honestly speaking, the main message is that long-term duration double and triple therapy gives a true benefit only in the subgroup with double stenting. There is no benefit in terms of reduction of ischemic events in subgroup of single stenting. So what do we have? Honestly speaking, guidelines now are very easy to read, and they suggest that double and triplet therapy should be decided on the base of the symptom at admission. So, but they can be modulated on the base of the bleeding risk. So we have to put the patient on 6 months if there is a stable coronary artery disease, on 12 months if it's an acute coronary syndrome. We can decrease if the patient is judged at high risk. Not in this case, we'll go through the 4 definition of high bleeding risk derived from trials. But we are now in a meeting about bifurcation. Bifurcation can be treated with double stenting, and double stenting can be planned or can be in bailout. These are situations in which we have increased thrombotic risk. So we should theoretically modulate in patients with a low bleeding risk. We can go at least to 12 months, and even more if the patient is coming from an acute coronary syndrome or in a bailout situation. However, we can depotentiate the therapy in case we have the use of intravascular imaging. We now have this possibility. When it's optimized, I do not go through if my case was optimized or not, because there were balancing from one side advanced age, from the other side the uncoverage of the proximal ostial circumflex, but it's real life. And so in these cases, we can decrease the intensity of the therapy, having a complex scheme, difficult to be used, but perhaps useful to someone of you, and I am now open to discussion. Thank you. I was on time.
So, your opponent, Marco, will be Georges Dangas. So, after left main stenting with 2 stents, we should prolong that up to 2 years. George say no.
Oh, great. Thank you for the invitation. It's a very challenging debate, and we see how things go in the end. We saw a lot of cases, already a case, very similar anatomy, I think, but I'm going to show, but in the end of my case. So let's see how it goes here. Okay, very good. So in general, we have to balance the risk versus benefit ratio when we talk long term. And what's happening, what we know is happening, is that ischemic risk may be confined in certain categories, but we have to be cognizant of the bleeding risks, and we'll be cognizant of the mortality risk. In general, in the acute coronary syndromes, stenting, complex stenting, there may be some benefit, but in case it's not in this range, then we probably have to be wary that we may have to end up losing a little bit more than just gaining. And also, we need to understand that a patient having a small MI versus a patient having a transfusion for a bleed, it may actually, the impact to mortality may be a little different. It's not exactly clear how much, but it may not be as traditionally associated mostly with the MI as we thought, maybe the opposite, and still an active investigation from all fronts. So, one of the risks for stent thrombosis, just to go to a little bit more technical aspect, is a small stent diameter. So I would say that left main doesn't exactly fit in this category, so we can go further. In the twilight, we saw that in patients with some elevated risks, the bleeding was a lot decreased with limiting the depth, quite frankly, to just few months, and there was no penalty in ischemia. The question, of course, is who are these twilight patients? And indeed, looks like the patient we're talking about may be included here. Bifurcation lesions with Medina, high-level Medina, including 2 stents. So there we go. Some of those patients we're discussing are covered on this very recent study that indicated that we don't really need a whole lot of depth overall. I think we covered that as well. So in real world, the patients tend to be either high risk or low risk, but we're focusing a lot in the bleeding risks that is multifactorial, as we see. Aging, comorbidities, laboratory factors, they all play an interplay, and everybody these days try to look for high bleeding risk populations, and even there was an ARC document and ways about that. Interestingly, what may be a deal breaker in this debate may be that is in this particular aspect of the left main, we could have the intravascular imaging as an important modifier, because in these particular lesions, we may have more intravascular imaging utilized by everybody's kind of push and indication and discussions. And indeed, in some studies that stopped up too, that they had a lot of intravascular imaging, they had a lot of good results, even without a lot of depth. Hard to say that 2 years of that. These guys did a great, even with just a couple of months or so. And indeed, the maximum benefit of intravascular imaging is in general evident from other studies as well. That's an example of people who did or did not use an intravascular ultrasound, and you can see either in the IVUS Excel and in the ultimate randomized trial there was some benefit. So as far as my case presentation, and I only have the still frames in order to gain some time here, no movies, in this experienced audience. This is how we started with a diabetic patient, left main double vessel diseases, codominant circulation. Technically, there is a small PDA, but not that big. And you can see that the patient had a lot of extensive disease, underwent for bypass to the left main with LIMA2 LAD, etc. Actually, per patient, strong preference, quite frankly. A few months after the bypass, the patient was referred back due to recurrent symptoms and nuclear stress test indicated that there were 2 of the 3 grafts completely closed and some modest compromise of the last graft. So in that situation, went to a very highly calcific lesion indicating both vessels, chose to do quite a bit of rotational thorectomy down both vessels. For this reason, chose to have hemodynamic support during the case. And in the end of the day, we had a lot of a very good result with great IVUS-guided, I would say, stenting procedure. So in a case like that, we would feel comfortable with this kind of measures that we would have a very good aspect of that, a very good result. Let me point out something that may not be exactly related to our debate, but maybe also interesting, because I would try to gain, when we talk about a complex lesion population, lessons learned from other complex lesion population. And I picked up this study from this year as very, very important one. Is a genotype genotype-guided de-escalation of therapy in patients with STEMI. I would say if the patients with STEMI are able to de-escalate and come off to an intensity of depth early on, why not we could use some of that perhaps in our future meetings and see how those may go in the high-risk left main double stent patients. So in summary, and I did save some time for you for the discussion, a prolonged dab after a year may prevent indeed some scarce ischemic complications at the expense, however, of bleeding complications. And the major bleeding is a very important predictor of subsequent mortality, more so than the minor levels of troponinology that we get here and there, but even with minor events. The short depth followed by a P2I2 monotherapy decreased bleeding without an ischemic penalty in the Twilight study, including complex PCI patients, and I promise we're going to have the dedicated Twilight complex secondary analysis in the ACC 2020. We're currently figuring out ways to do that. On the other hand, new regimens of cessation appear very promising in complex patients. I highlighted the specific one indicating the genotype de-escalation, that not only abandoning the double therapy, but perhaps even reducing its intensity in favor of lower cost in selected patients. So in the end of the day, I think in the real world patients undergoing PCI, many of them are high risk for bleeding, and I would not prolong the DAPT any more than absolutely necessary. Thank you for your attention.
Thank you very much, George. So now we have a discussion with you and with the panel. It's true that these old patients who have left main disease are also those patients who are bleeding. So we have to find a good balance between the length of the DAPT and the risk of bleeding. So what is your opinion?
You see, the year-long DAPT was decided long time back, 2001, on a PCI cure. And since then, we are continuing 1 year only. And then only in 2016, we had a DAPT guidelines which said that 6 months for stable and 1 month for ACS. But now the need for reducing the DAPT medicine are important because large number of patients have a high bleeding risk. In fact, all patients in my practice are anemic, which is a major factor, and half of them are aged, which is a major factor. And if I say that left main bifurcation when you're taking is 50% or more are high bleeding risk. And in these patients, increasing the DAPT just because we have not done the right procedure. But it's important that these 3 trials, one on X1 and one seniors, one and all those biofreedom trial, they have said that if you do the right stent and the right procedure and optimize the strategy, then you may not require the DAPT for long years. So I think that what is required is to use the better stents with low thrombogenicity and do an optimum job with the less, so that a complete procedure is done rather than increasing the DAPT. Increasing the DAPT, we don't find a reason in this particular population where the DAPT can be reduced rather by giving the optimal results and using the better stents. Thank you.
Patrick?
Yeah, I think that we have to remind the audience that this year in the European Heart Journal we have reported the global leaders, 16,000 patients. And what we did in that trial is that we took the table 9 of the guideline of the European Society. In this table 9, there is basically 5 factors relate to stenting, which is double stent, multi-vessel stenting, multi-lesion, and so on and so on. There's also a few characteristics typically relate to clinical characteristics, but we took the 5 parameters which were related to stenting. And we had a surprise to see that with the short monotherapy, 1 month aspirin, and then 1 year of even 2 years of P2Y12, a specific and potent antiplatelet agent, we had a considerable reduction of bleeding without having a penalty for ischemia, something very similar to what you see in Twilight. And this morning I was mentioning that we look also in Twilight like in the global leaders, and we got basically the same type of result. You can afford to have only 1 month of aspirin if you use a potent and specific P2Y12. And then very soon in GACC, we have only look at the multi-vessel disease, but in this multi-vessel disease, there are 400 main stem in global leaders. So it's a quite reasonable population of main stem. And again, we have the same message. You don't increase the ischemic risk, but you decrease the bleeding risk. So I think there are some evidence, and the only thing I mentioned this morning is that sometimes I have some concern for the ischemic stroke because that might be another story, but we have to pull this data to see if this signal is real.
Okay, if Louvain has something to say.
I was surprised that we are speaking of high bleeding risk, we are speaking at high risk of ischemic event, or very high consequences for ischemic event in the territory of the left main. But the third partner, the double stenting, the simple stenting, and the techniques were not touched at all by the two speakers. So one question. George is working in Mount Sinai. Mount Sinai is a place where Samin Sharma is working. I know he's still doing SKS. What are you doing when you are, especially for unstable patients or acute coronary syndrome? What is the politics of antiplatelet treatment in these patients?
SKS, we don't do that much. SKS is performed only in some kind of a true V configuration, not anymore, in an extremely unstable patient in order to save time. That's the only time we use SKS. Otherwise, we go with the nano crash or ultra mini crash, modified TAP, however you want to call the technique, or DK crash in some instances.
Because I remember, I know Samin Sharma since a long time, but I remember a few years ago, he was telling that after SKS, it's better to give DAP lifelong. So lifelong is something which is clearly not realistic.
Well, the stents...
If you are dealing with the left main in all patients.
The stents got better from a sense.
So now, if you have a question about other techniques, for example...
I just have a question to Dr. Simarino. I like your aspect of adapting the DAPT therapy to the intravascular imaging. So,
the last slide.
Do we have any data for this concept?
Data are only derived from the increased risk of the strategy. Meaning, we have a couple of papers, one from our registry, another one from Francesco Burzotta, meaning then over double stenting, bailout stenting has an increased risk of adverse thrombotic events. But there are no data at all about the modulation of the therapy on these subgroups of patients. So I inserted in the, if I can have the last slide, I inserted it in the last slide, not entering, you are right, not entering the detail of which double stenting technique has been used. But I think that it's correct to go through intravascular imaging optimization, yes or no. Because if we enter the various strategies, we cannot have enough data to...
Thrombosis, thickness, and overlapping.
Absolutely.
So if you put 3 layers of metal, even if it's well compressed and completely crushed, you still have 3 layers of metal.
I absolutely agree.
The lesson of the study, the BVS, lesson of BVS was this. The thickness was creating a risk of thrombosis.
Absolutely, yeah.
Especially when some technical mistake was done. But
yeah,
thickness is a factor of...
you remember that last year at ABC, I was presenting the 2,600 bifurcation, the global leaders. And my talk was a little bit, had a tendency to say that in two stenting, it would be better to have a long DAPT. I must confess and admit that when we went to the publication, and it's today published, of course, the adjustment came into the games, etc., etc. I was presenting crude data at that time because it was a novelty. It was just a month after the presentation of the main result. But after adjustment, we could not prove anything. And as you say, the SKS is a rarity. I mean, in 16,000 patients, you have something like less than 60 patients who have that kind of treatment, so you cannot draw a conclusion. So it was somewhat disappointing, but that's the statistic. If you go for adjustment, finally all these curves are very close, and there is no low rank difference, yeah.
I would not dare to disagree with you, Professor Serruis. But in the paper of in the subanalysis by Francesco Costa, I do not remember. I had it in the list on JCC. I think, perhaps JCC, not JCC intervention, very recently published. They had a slight benefit from double therapy in the subcategory of patients with complex PCI and less than 25 precise depth.
Francesco, that was in Matrix, I guess, yeah? Francesco in Matrix, Francesco Costa have a signal, but of course we were desperate to confirm that message, but we could not.
I have just two comments. First, the Korean study that you have shown, when we see that patients with 2 stents have a better outcome when we are on longer DAPT. I've read the paper in details, and there are no difference in stent thrombosis. So the difference is driven by more ischemic events in the 2 stent group, meaning that this patient had probably a higher burden of atrial thrombotic disease. This is one comment. And the second thing is regarding global leaders and Twilight. I think the ticagrelor monotherapy after a certain amount of time is very appealing. But then it confuses a little bit everybody because we are not talking anymore about DAPT. It's a single antiplatelet therapy, but a very potent one. So it's like at the end, if you go for ticagrelor, means that you give a potent.
No, but the message is clear there. I mean, you should not get obsessed by the technical aspect that you have to stent. You have to make the adjustment, and in the adjustment, you have plenty of other reasons to give that therapy longer. That's another story. So every time you isolate only one thing, you go wrong. You have to take the whole picture.
I think the point about the intravascular imaging may be self-explanatory. You don't need much studies. If you're not happy with your result, you may indeed use an equalizer. It's just that it's going to be, hopefully, in experienced centers, a really small minority. For the most patients who are going to be happy and who are going to go shorter.
So one of the messages is a la carte treatment according to the final result that you have, but it could be 1 month, 6 months, 12 months, maybe not more, we don't know. So it's time to vote now. So you go to Slido and
we had not to forget the Pegasus, the Pegasus trial. Today we say 4 months.
So far, nobody's voted.
It was 30 months.
I will ask to Dr. Serruis Professor Serruis, if you give ticagrelor for 2 years, okay, like in global leaders.
Right, and you could do just 1 year.
You could do just 1 year.
That's the big message. I mean, there's no benefit the second year. That's where we shoot in our foot.
Okay, thank you. Thank you.
Professor, but how can we deal with the result of Pegasus then?
I mean, it's not exactly the same type of population. And what you are really discussing now is 1 stent versus 2 stent, which is a very technical affair. Let's face it. If you get obsessed only by that, you are not going to do good medicine. But that 2 stent might have a tendency to bleed, might be an old lady, might be a COPD, so you have to take the whole pictures. And that's what we kind more and more in what we call precision medicine, to try to see what kind of patient you are dealing with. And it's difficult because medicine has to be individualized every time.
And these patients are usually the same. So the patients who are bleeding are also the patients who have more severe disease. So
it's sorry. So the result. It's
I
no.
have no doubt. I have no doubt.
74% no. Yes, 26%. Yeah.
So less than 1 year.
Yeah, remains the.
Yeah, the no is a blue. You see that the Greek people in the vote voted for no.
Okay. So we move to the next debate, which is also a burning question. If you use a crush technique, it should be a decay crush. So we all invite the first speaker. Is Dr. Chen or I don't know. Sorry, it's going to be Dr. Sheban.
Good afternoon. Yes, I am not Chen. I'm trying to say what Chen
to use the small one. It's better.
Just go ahead.
Okay, let me just go back. Is that was the jars?
Just to go ahead.
Just a second, and you can try it. Go ahead, try it.
Okay. So I'm trying to take the part of Chen in convincing you that when you are using crash technique to use DK crash. First of all, I think that we should recognize that this is not a conventional bifurcation. What we are speaking about is distal left main. It is two main vessel bifurcation. So every time we should optimize what we are doing. And if we look on EBC recommendations, you can see that when you have some concern about side branch, DK crash is indicated as a quiet gold standard, or you can also move to other approaches, but again, no other kind of crash is indicated there. So only DK crash from the family of crash. And in the European Society guidelines, also we can see that it was indicated as the preferred two-stent approach when you should move from provisional to two-stent technique for complex bifurcation. But it's not moving?
No, it's not moving here. Just a second. Because we got problem issue. It's on the screen. Is that one? I'm gonna restart. We need to wait a few seconds.
So let's see.
You all know any joke?
Yeah. Okay. If we go...
Still
sorry?
a problem. We got a problem with the signal.
Oh, it's not, you don't see anything there. Okay. I see that very well. So, okay. Now go back. Changing this.
Okay.
I have the image here.
You don't have to. You're gonna have to use this one. So you
okay.
use the backup.
Okay. Okay. Now it's not moving anymore. Okay. So what is important, I think, is to, if you are performing decay crash, I think you should go every time step by step in order to optimize what you are doing. And just to go quickly in step by step, this is a case with complex distal bifurcation left main and predilatation, wiring and predilatation, then assessment by IVUS is almost recommended for any two-stent technique, but particularly important in decay crash. And we'll give you an idea about distribution of plaque and how to start your and optimize your choice. And this is the first step, stenting, implanting the stent in circumflex with the simultaneous balloon in LAD. After stent deployment, second step is to crush the stent with the balloon already positioned in crossover left main LAD. And then this is a very important point, the recross to circumflex should be proximal this time, not distal, because if you are crossing distal, you might cross outside of the stent and then with reentry, and then everything will be much more difficult or complicated. So proximal crossing. Third step is to crush again with balloon and first kissing. After first kissing, implantation. Fourth step is implantation of the stent in main vessel. And then again rewiring, doing pot first, fifth step, and again rewiring, and rewiring circ, again try to rewire proximal or mid side branch, not distal, again for to avoid or to prevent any crossing outside of the stent. And after this, sequential post-dilatation in side branch and left and main vessel, and again final kissing, that means second kissing, and finally seventh step is the pot, and this will be the final result, and again is highly recommended to be guided by IVUS. The optimization, final optimization should be guided by IVUS. And if we look about the differences or the advantages of decay crash versus classical crash, we see that there's much less struts layers at side branch ostium, but better position of the stent at the ostium as well as in the whole side branch, larger mean stent area. So these are all given the reason why to use decay crash and not classical crash. Besides this, you see that when classical crash is done, then 20 to 50% of cases will be quite impossible to recross with another balloon or to do kissing, and this might affect negatively the outcome in classic crash, while this is almost possible in 100% of cases when you are doing decay crash. If we go to clinical support of what I'm saying, is you can see that this is the first decay crash study showing the significant difference between the significant benefit of decay crash versus classical crash in terms of reduction in target lesion revascularization. And if you going against a classical crash without final kissing balloon, then this difference will be much more evident. And not only against versus classical decay crash, classical crash, decay crash was proven to be also superior to Culotte stenting in decay crash study again. and versus even provisional stenting. This is the series of DK Crush trials, DK Crush 1 versus classical crush, provisional stenting, Culotte, and again provisional stenting. And I should underline that provisional stenting in these studies were referred to complex bifurcation performed with provisional stenting. Then two stents technique and DK crush technique in this case were doing better, having better outcome. So my final message is for complex left main bifurcation lesions, two stents technique, especially DK crush, is associated with excellent clinical outcome. And serial randomized clinical trials were able to show and demonstrate that in complex bifurcation, DK crush is associated with better clinical outcome as compared to other technique, and particularly with the classical crush, and should be considered as gold standard when crush technique is used. Thank you very much for your attention.
Thank you very much. So the question is, if we use a DK crush, I know. If you use a DK crush, it should be. If you use a crush, it should be a DK crush. So the next presenter will say, no, sometimes I use a crush, and not a DK crush. So it's not to compare to other techniques, so it's compare DK crush to crush.
Okay. Okay, let's write me down something.
Writing down things here.
Okay, let me do something first.
So who is performing DK crush on a, let's say, regular basis when you have to do a two-stent technique here?
And we're still using crush?
The classical crush?
No.
The classical crush?
This is the purpose of DK crush or other improved crush techniques.
You know, I presented already 1 year ago and yesterday a presentation here at EBC showing what is proximal side optimization. And it makes to pull out the delivery of side branch stent, inflating higher pressure and go there with high pressure balloon bigger. And when you optimize the apposition of side branch at the osteon of side branch, then it's more easy to recross, and you have a better result there.
Yeah, it was the purpose of DK crush, but of course there is other approaches like your approach. The purpose was to improve the rate of final kissing balloon inflation, because with classical crush it was very low, and then it impacted the outcome of the patient. So that's why we decide to have this discussion today, because we have seen in the world everywhere crush techniques. So that's why we, not DK crush, crush technique. So that's why we decide to have this discussion. Should we continue to use crush? Because we have better than crush. We have DK crush, or we have maybe your technique, but it's not compared to other techniques.
See, the essence of DK crush is that we do better crush. Okay, that is what we are trying to do. And in DK crush 5, only 40% of the patients have done IVS. Whatever my learned speaker said that IVS is mandatory, but it was not done only 37% patients. So if you are not using IVS, then DK crush should have been used, because that's the time I want to optimize the results. But if I can optimize my results with a good imaging, then what is the necessity of getting into so many complexities and requiring, I do DK crush, but I do DK crush when I'm not using IVS. If I've got IVS, I will do a better crush with the under stent crush also.
Yeah, but one of the problems is that in many countries they cannot use intracoronary imaging. So we should have a technique which can be applied everywhere in the world.
But that is complex. So that is more difficult. So you are opting for difficulty. Onus is on us to do the better job. The better job, if can be done by IVUS, I would use IVUS. If it is better job cannot be done by IVUS, then I like to do decay correction.
Well, thank you. I think my arguments have been made. So, these are my disclosures. And I am a fan of the DK crush. I think it's a wonderful technique. So you may ask, why am I arguing against it? Because Goran Stankovic asked me to. And because it gave me a chance, I think, to really think about the whole situation, you know, DK crush, other crush. Why was the crush even started? The crush was started, I think, accidentally because Antonio pulled a side branch stent too far back into the main vessel, and hence became the crush. And I think Goran, actually, I'm not sure if he's here, but Goran is the second author, I believe, on that publication. It's correct. There he is. And of course, this is how the technique was initially described, I believe, in the spring of 2003. And by November 2003, we actually, after that publication, saw this, you know, the light went on, and this was the first time with drug-eluting stents, with Cypher, that we could have a 2-stent procedure to work on complex bifurcation lesions, which, of course, prior 2-stent techniques done in the bare metal stent era, Culotte was associated with 80% stent failure or procedural failure rates at medium intermediate term. So we were quite excited about this, but we were major transradial operators and 6 French, and this was done with 6 French, so therefore it was a balloon crush, which was, again, kind of a leap in faith. And I understand from Imad that around the same time he was already doing sort of a modified DK crush procedure with Shaoling in Nanjing. So we were kind of doing this in parallel. But we also soon realized that all this did was it enabled you to do this through a 6 French system, which is kind of a big deal when, especially in Cypher, you definitely could not get 2 stents through Cypher stents through a 6 French. You can barely do it now sometimes. But we still had the same difficulty in rewiring, and that's the key, I think, is the rewiring through the three strut layers. And number 2, because of how those 3 strut layers are conformed, you're never going to get optimal expansion and optimal coverage or opening, if you wish, of the side branch ostium. Almost never, or rarely. So very soon after that, we modified this by actually recrossing in the same way that the DK crush is done, recrossing the side branch struts first. And this is the first case of that in the first IVUS, showing excellent opening of the side branch ostium with IVUS. This brings us to 2019, where we've done a lot of these procedures. For some reason, this is not, there we go. This is a complex 2 bifurcation lesion in a patient who's not a surgical candidate, who was brought to me for complex procedure. And so in 2019, if this ever works, we end up with a 2 double DK crush procedure involving both the large LAD and large diagonal, as well as the left main and circumflex. And maybe that'll work, but it's not working. So it's all good, and this is another case from 2018 showing a great result. He had some atypical symptoms, this patient, so we brought him back for recath. We didn't do an OCT the first time around, thought we better do one at follow-up. This was about 9 or 10 months later, showing an excellent result. Now, unfortunately, I'm not sure this is going to work because I was able to run this up there, but I think this is just, for some reason, not running. Okay, never mind. What it shows is that there is kind of a double opening, so in other words, a neocarina and then a space in the carina, at the ostium of the side branch. So it's not certainly perfect, even though angiographically it looks great. It's a DK crush. It's a DK crush as I would normally do it. This I've shown before, I'm sure, and of course it's not running again, so it is a little bit, okay, there we go. Okay, just run it and we'll take a minute. Just look at the carina and look at the very end when it starts to come back, there's some malapposition. So I think this is because of the DK crush, because in fact you are creating a little bit of a neocarina, and this will come up again, I hope, so you can see it again later. So there are malapose struts there at the carina, and potentially these could cause trouble in the long term. So I think that this is actually inherent to the DK crush. So we have done a procedure that's similar for many years until I adopted the DK crush, because it's slightly simpler than the one I had done, which is a double crush technique. And so this is a mini crush which shows big accumulation of material. This is actually plastic material. This is absorbed material at the carina. And this is my caution, because I would actually argue with recrossing very proximally here first time around, because if you recross very proximally when you're recrossing the strut, you're going to end up with a massive neocarina at the end. So my approach is to actually do a middle crossing, recrossing, rather than a proximal recrossing. So this was a mini crush that we did at the Abbott lab in Santa Clara, and I think Antonio was also there just prior to that. This is a double crush, so this is, instead of doing the first kiss, you actually crush so that you don't end up with stent material into the wall of or into the lumen of the main vessel. And you can see perfect circularity. In C, you see the picture through the side branch struts into the main vessel. Never mind the little spicule, that's just a plastic stent fracture. We don't get those anymore because we're not using plastic stents at this point. But otherwise, a perfectly round circular opening into the side branch with the double crush technique. Brings me back to the modified mini crush, okay, because the modified mini crush actually has very good results, and there haven't been large trials doing this, and I'm not sure that even Xiaoling Chen, when he compared the DK crush versus a mini crush, that this is the kind of a technique they use. So this was described by Yang 10 years ago, and it's a very detailed description. The important thing is that this is almost like a nano crush, really. Not quite, but almost like a nano crush, in that if you look at the second heading, the proximal marker actually ends up touching the stent, no more than that. So not 2 or 3 struts into the main vessel, but where it just barely touches the strut, so you get really minimum stent material of a triple layer nature. You still have to recross, but in this particular study, which then they described their experience a few years later of modified mini crush technique, they showed superb results compared to the standard crush. As you can see, at 3 years, MACE 25%, classic crush versus half that, 12.6% with the modified mini crush. Death rate even is considerably lower. So at 3 years, these are for complex lesions, really great results. So in summary, the DK crush technique is a great technique, but should not be the default crush technique in all cases and for all operators when a planned 2-stent technique is needed. Other crush techniques may provide results that are comparable, and head-to-head studies are needed. Thank you.
So Vladimir, in which cases we are doing a crush instead of a DK crush?
I do the DK crush. I don't do the crush personally. Well,
So
I
maybe
just
it's
I
not
just told you
necessary to vote.
I gave you my disclosures before. Okay,
Yeah,
so
yeah.
this is an argument, but in looking at the literature critically, this is what I'm finding. So I use a DK crush because I find that very predictably it gives you complete coverage of the ostium and the best opening. The crush techniques do. The nano crush that was described earlier, I have a bit of an issue with because I'm not sure that you can tell angiographically whether you actually covered the entire ostium. So that's my concern about the nano DK crush. I'm sorry?
You don't need to cover all the circumferential of the ostium.
Why don't you? Why don't you?
Because you crush, you do an in-crush.
Yeah, but you are not talking about the same technique, because your technique is a special T-stenting, systematic T-stenting technique, or micro T-stenting.
Yeah, so I mean, yours is not, I don't think you're the only person with, I've seen other nano descriptions as well, where in fact, it's the distal edge that touches the carina, right? So in that case, depending on the angle of the bifurcation, you actually can miss the proximal, and unless you're able to, as we do in provisional stenting, then in your second wire recrossing, recross distally, which I would also recommend with the DK crush, is that the second time around that you recross, you do distal recrossing so that you get that flap of stent material into the proximal edge of the side branch. So the first time it's a non-distal, as we I think described in a paper recently, and the second time it's a distal, because by then you're not worried about going abluminal distally. By then you actually have optimal coverage distally, so you can go distal and then get that side branch coverage if you haven't got it in nano.
I have a question. So the main goal of the DK crush is first to not miss the ostium, and second to have a nice opening of the side branch ostium and to avoid a bunch of struts in front of the side branch. But it's the only caveat is a little bit time consuming, a lot of steps to do. So another provocative technique that I perform in my cath lab is that I do the crush. So I place, the first step is the same, but then I don't do a kissing. I just open the side branch with a high pressure non-compliant balloon. I put the main stent, I rewire, so most of the steps are the same, and I do a spot side pot at the end. So why do we need a kissing balloon as the second step? Why? Is it a true reason to do that, or?
Well, I think that kissing balloon will give you the possibility to expand the stent, fully expand the stent, without deformation after putting the second stent. That'd be preparation of main vessel to receive the stent without any pushing on the crushed stent. And what is you are saying that crossing after putting the second stent distally, you take the risk anyway to cross behind the stent, because sometimes when you are crushing, if it is not fully opposed, you still having some gap between at the opposite side of side branch.
So I think the DK crush is a living technique, you know, and it's we've already changed it, and I am now doing what's called a pot crush. Okay, so that instead of doing a pot crush and a kiss, if you wish.
But this is a recommendation of Shen also to do pot 3 times.
Exactly.
So it increases the complexity,
so
not the complexity, but
Can I
the
just
length
try
of the procedure.
To answer the question,
go on.
because the reason why first kissing is done is because with technique that you are using, you are pushing metal into the center of the main vessel, and sometimes they face problems crossing with devices afterwards. So the main issue of first kissing is to simultaneously inflate 2 balloons and shift metallic carina into the center outside of the main vessel. That's the main reason.
But do you have imaging data to prove that?
Well, you know what?
I'm just trying to answer your question based on presentation of Shaoliang Chen. I spoke with him, and whenever you meet him, you can continue the discussion.
So Shaoling has done model testing that he's published that showed that, but I have personal experience of having that happen to me. So the first
description we did of the modified balloon crush, which was like the DK crush except without the first kiss. Okay, Shaoling wrote a letter into CCI. Actually, he did the editorial on that paper, and criticized it that you had to do that first kiss because otherwise you might have trouble getting, because of the winging of the distortion that occurs even in the crushed and now recrossed stent. When you balloon through it, you cause distortion, and you may have difficulty getting material stent even balloon past that on a wire. So I wrote back, said no, that never happens, and I had 2 occasions where that did happen. I had to get my way out of trouble actually with road ablation.
I have a question regarding.
That's why that's important.
I have a question regarding the convincing results of DK crush. Of course, they are very convincing the results, but I think there's a bias because they are very experienced operators. So the question which comes to me is, if you would have less experienced operators, do you think the results would be the same?
Well, I'll let the protagonist answer that first. What? Sorry?
So Tom, what is your comment?
Which should less experienced operators do this?
I mean, the operator experience is very important, of course. Operator experience is very important, of course, but in crashing anyway, whatever you are doing in crash technique or any other technique, you should have specific experience. And this is coming by training, by doing, with somebody who are tutoring you. That is what is recommended for every approach.
I find
out of provisional stenting, maybe.
I find that an interesting comment, though, because when you took a poll in the room, I think the majority of people here have done DK crush, and I think everybody in this room can do DK crush properly. Yes, there are a number of steps. There are probably 8 or 9 of them, okay? But that's only 8 or 9 steps. It's to get a good result in a patient with an important bifurcation. It's not such a big deal. So I think anybody can learn to do this.
Tom.
Although I think what's intriguing, this is a circuitous discussion that we've had now for a few years about the pros and cons of individual techniques. And yet we've seen at lunchtime the most exquisite images of what we don't see when we're doing these techniques. So regardless of whether it's DK crush or Culotte or any other approach, we cannot truly tell where our wires are going and how we're interacting with the devices. So I think there has to be a caution, and we just have to remember with every technique that there will be a potential pitfall. For me, I use both, but my most compelling reason for using DK crush would be a fear of losing one or other of the branches and it offering a security. And so it would only be in a select cohort that I would use that, where Culotte would be preferred in the majority.
Yeah, Tom, the question is not between different techniques. We are talking about crush. If you do a crush, it should be a DK crush, yes or no. So we are not talking about other techniques.
So I think
and the question is just because the DK crush technique improve the rate of final kissing balloon inflation. It's 100% if you follow all the rules, versus 80% if you do a classical crush technique.
Yeah, so I think it improved because improved because of change in strut thickness and improved because of operator experience. So even in Cactus 1, Antonio and the group had, I believe, 95% final kissing balloon inflation. In this study that I cited, they had 97 or 98% final kissing balloon inflation from China. So I think it's about that as well, and we have much thinner stents now, and it's easier. And also, if you pot, you're also going to make it easier. That initial pot is
last
really
comment
important.
from Remo.
Yes, I want to just give you another point of view. Antonio,
excellent.
Yes, okay. Antonio, so he tried the crush. Then he also tried to do a dedicated stent. Remember? The capella was his idea. It's the same concept, to protrude some. If you have ever used the capella, the problem when you use the capella, you can't cross with the main stent because the capella protrude in the main vessel and then you catch the stent. So the main problem when you do this side branch first stent is to optimize the stent that protrude.
And in addition, if you have experience with side branch first, if there is not a lot of a long lesion, sometimes you put the stent as a T, not a protrusion, and then when you put the main stent, the stent migrates, even distally. So the main purpose of decay crush and the reason why it is so successful, because when you do decay, double kissing, you anchor. Because you don't, when you put, it's not a distal or proximal, it's lateral, because the balloon, when you crash the stent, crash the part laterally. So you have the detachment not from the carina, but from the side, because you have the protrusion, then so you have to anchor. This is a small anchor, and then you prepare the main vessel. And so if you do a kissing first, and because you prepare the vessel, you anchor the side branch, and you go, it's the best way to do.
And by the way, somebody said earlier that, I think you said that it's the kissing balloon inflation that optimizes the ostium. It's not the kissing balloon inflation. It's the recrossing and it's the high pressure inflation that you do in the ostium before you do the kiss. The kissing balloon should never be a high pressure inflation. And whether it is or not, a kissing balloon will never give you the best opening in the side branch ostium. It's the inflation that you do before that kissing balloon inflation in the side branch through those struts initially.
Also, kissing balloon also to keep good expansion on the ostium side branch. I think the main point why to use decay crush is to avoid having 3 layers of stent, 3 layers of struts over in front of side branch. This is giving less expansion in bench models than in human will be much more less expansion if you still having 3 layers. And that's, I think, the main motivation.
Okay, so it's time to vote. So if you use a crush technique, should it be a decay crush? Yes or no?
I'm happy to lose, by the way.
Can we see the vote? How many patients did vote?
But you have to vote.
No, it's not finished. Did you vote? Oh, yeah.
I voted.
You're not voting? Okay, I'll vote for you. I'll vote for you then.
Okay, so let's have a look. Okay.
You win.
Congratulations.
Me. Both, you win both because you are both doing decay crush. So.
Yeah, no.
So it means that there is still 19% of people who are doing crush without doing a decay. So interesting. Okay, so the next question. So maybe you can introduce next question.
Yes.
A lot of debate again.
When treating a distal left main with provisional approach, we should systematically remove struts in front of the side branch. The first speaker is Mr. Nakamura.
Thank you. So, after single stenting crossover, do we do the remove the strut in the circumvessel area? Yes. Actually, he is 4 years ago. Actually, 4 years ago. Pretty much left side. Fact number 1, human instinct. People in jail want to free from jail. So especially want to touch in jail, especially in an intervention cardiologist. Fact number 2, malposition. Mostly may lead worse clinical outcome. People want to avoid. Fact number 3 from the middle registry with Antonio Colombo. Toru Nagama was my junior. he reported actually the circumference ostium itself independently showed a high responsive patient left main PCI. Fact number 4. What is the initiation of the circumference ostium? We do a lot of the OCT study in these 10 years. Yusuke Fujino, my junior, he reported in a JAK intervention, JAK imaging. Actually, if you do left main stenting, left into the ALD, and this is a cipher, so cross cell, even after the KVT, we can see multiple sensor. Around the multiple sensor, we have a neoadjuvant preparation. Currently, we know this is, I think, one of the main reasons of the cause of restenosis. Fact number 5. What happened in the multiple stent area? We do also the collaboration study, the Tokyo University of Science with the flow dynamics study. Actually, this is just an experimental model. Anyway, left panel shows the no stent, right panel shows the stent. There is 2 stent, and with the multiple sensor. We easily understand. If you do contrast, we cannot understand what happened, but we can easily understand. If you do the stent and we have a multiple sensor, may change the shear stress. Interestingly, if you do the lot of the actually many stenting technique, flow pattern is different. The most importantly and most interestingly, if you do the same stenting technique, this is a Culotte. Middle panel shows multiple sensor. The some case no multiples, some case multiples, and also flow pattern is different. And this is actually the top stenting after they said final angiogram, and then we check the OCT. Those show the multiple sensor. Even anyone can say this is our very good result, but actually that's kind of multiple sensor made restenosis. Also, we have a test of this is just an experimental model. Middle panel show the ideal one, right panel show the not ideal one. Actually, flow is lowering, causing turbulence. Easily understand this is one of the reason of the restenosis. Yusuke Fujino, this is my junior, he reported, depending on which stenting is used, flow the circus will be different, even whether the favorable stenting is achieved or not, makes the flow pattern different. Of course, we need to check the clinical relevance. Anyway, fact number 6 is we have a good method to recross the good point. Actually, Dr. Okamura was here, and also the Dr. Onova. We have 3 important papers. If you use OCT guidance, we can recross the very good point, and we can do the good kissing. He reported, they reported. Fact number 7, clinical relevance. Actually, unfortunately, we don't have any data of the which shows anyway patient have a multiple sensor and maybe the restenosis or not. We don't have any clinical relevance. But actually, currently we have data. This is our hospital data. Current 50 case double stenting technique, and then we divided the 3 groups: no multiple sensor, slide multiple sensor, swing and multiple sensor. And then clearly we can see the swing and multiple sensor group show the high restenosis rate. Of course, this is a limited number and the bias, but this is one tendency of the clinical relevance. Of course, we have an opposite fact. Anyway, KBT, it's a kind of our common sense in this 30 years of history. But actually, common sense is a correction of the prejudice, he said. Anyway, the Dr. Okama showed the very clearly, beautifully demonstrated around the circumference ostium area. And then he reported the influence of guidewire recrossing point on the incidence of implanted stent apposition after the kissing environment. And then divided the 2 groups, link-free and link. So actually, the point is only 50% link-free. That means only 50% of the link-free type. And then if you do
good position recrossing, we can decrease the stent malposition. But on another 50%, maybe, I don't know the result, but maybe I think it was. Opposite fact, number 2. And yeah, we have several papers. Actually, this is AOE registry, which is one of the biggest left main registry and conducted by the Kyoto University Group, and Dr. Culotte was here. Anyway, they reported final cavity after single stenting, left main bifurcation lesion did not affect adverse cardiac event. And this morning, my junior reported the left main single crossbar stenting cavity or not. Actually, in the era of the second generation DS era, actually no difference. And finally, very important paper, I love it actually, very important paper from the Korea. Actually, Dr. Nam and Dr. Kuo, he's here. Single stenting without circumference slat opening. And then they checked the FFR. No ischemia FFR will show the good clinical outcome. That means FFR guided circumference deferral is feasible. Those 3, it's very important paper, I think. The opposite fact number 3 is a bench test. This morning, my junior showed that actually this is a bench test, but we call rectification effect. This means if he stenting and the alignment of the stent slat around the circumference area regularly, this means no effect of the flow. If we have some malposition may affect the flow. Anyway, we have data with pot plus minus, cavity plus minus, report plus minus, and check the flow pattern. And then clearly you can understand pot and compare the cavity. Only the flow volume the pattern toward the circumference improve. And after the cavity, if you do report, significantly improve the flow volume pattern. Anyway, so I think I should not do like this, but this is kind like this. So still yes, but conditionally yes. That means use OCT to check the condition of the GS slat, and luckily enough to have not have a link position in a circuit consortium, and need technique to get a good recrossing through the circumference, and apply the cavity, apply the pot. Of course, we need to chase the clinical relevance. Thank you very much.
So we don't need the opponent. So Dr. Sheban will show that we should not always remove the strut in front of the circ.
I think no.
And maybe we conclude that we should do it.
Yes. Can I have my? Okay. I think all we know why kissing balloon was introduced and why it's kept in many cases. But I also think that we all know that kissing balloon inflation have some limitation. And also last recommendation last year for left main bifurcation treatment by our club the conclusion was expert consensus suggests that kissing balloon inflation should be undertaken if a subintimal result in the side branch ostium is clearly recognized or that possibly exists for downstream PCI in future. And therefore younger people or when you have stent implanted into, when you have LAD and downstream disease or possibly future intervention, you should go for a kissing balloon. This was the last indication. But we know that, the kissing balloon can deform. Every time you are crossing the strut of the stent, the stent can be deformed or malapposed, and depends on where you are crossing, as have been shown before. It depends on the design of the stent also. Sometimes you are crossing distally, but you can deform the stents equally. It is not guaranteed to cross distally and to have no deformation. And the other thing that sequential inflation also might affect, that means starting from lift main or starting from side branch or both together, can affect the quality of kissing balloon or removing the struts from the side branch front. And kissing balloon, optimization of kissing balloon have been described and recognized by all of us. That means minimal overlapping should be followed, and then this should be followed by pot. But if we look about the mechanism of side branch occlusion after stenting, is not the strut of the stent in front of the ostium, but it's plaque shift or carina shift, side branch dissection, spasm, or thrombus formation. And I think not all these situations can be just treated with kissing balloon. We know also that provisional stenting today is to select your stent accordingly to the distal vessel reference diameter, then going for pot. And if you don't have any compromise on side branch, you can see also your stent like this with very easy technology. That means the enhancement of the stent, and your angio is like this. I think you do not need any further intervention. Your intervention can be finishing here. And yesterday we have seen that this also in bench testing, if you are with this dedicated stent, when you are doing pot, only pot, without any dilatation of side branch, excellent physiological fractal geometry is obtained as well, and you do not need to remove struts. And based on clinical data now, I think have been shown some by the previous speaker, and Kobe's pot study. If you look exactly what on kissing balloon influence of kissing balloon inflation, pot seems to be more effective if no kissing balloon have been done, as compared to previous kissing balloon. So the question can be completely different if you have compromise of side branch, like in this case. If you have a compromised side branch, you have to go to check whether it is ischemic or not. And if it is ischemic, you can correct it just with small balloon, that means small diameter balloon inflation, and come back with a good FFR and keep it like this. Then if it is small balloon, even in these cases, the correction is to plaque shifting, not to move the strut from the ostium of side branch. And in these cases, of course, you can have also a benefit on long term, as have been shown previously. Clinical data on systematic final kissing balloon inflation, whether before or followed or not by pot, showing that if you look on MACE, focus on MACE, you can see almost kissing balloon inflation is almost having more or associated with more MACE than non-kissing balloon inflation. This is also confirmed by other meta-analysis, also in lift main randomized clinical trials. You see that inflation, kissing balloon inflation, have been done in only ranging between 41 to 51% of cases, and mainly in two stents technique, not in provisional stenting. And this is the latest data coming from Excel, showing that in final kissing balloon in Excel study do not impact the outcome, clinical outcome at 4 years. And this study have been shown before, showing that no impact in this registry, as well as in this study from our group, no impact on final kissing balloon in patients treated with unprotected left main coronary artery disease with thin struts. Again, no difference between doing final kissing or not. So my point is, do it only when it is necessary. It is necessary when you have some compromise on side branch, or you have a patient having angina, ACG modification, or TIMI flow 3, less than TIMI 3 flow in side branch. Thank you very much for your attention.
Thank you very much, Imad. So we have few time for discussion before voting. You have a comment?
Yes. So the question here again is what do we risk to open the strut towards the side branch? So we have seen the presentation of Dr. Nakamura, and now it's becoming a little bit confusing because you have to do an OCT, you have to be in the right cell, so you could do bad job if you just open the side branch and you are not in the right spot. Regarding the kissing, I fully agree with what has been said now. Maybe just a simple pot side pot will be enough. No need, for example, to do a kissing. That's just another question. So just to open the discussion.
So the question was not should we do a kiss. The question was should we open the strut toward the side branch. It can be a pot side pot. It can be a kiss.
In provisional stenting.
In provisional. So we are not talking about two stent techniques.
Yeah. But Dr. Sheban added some data about the detrimental impact of kissing if you do it in the left main. So I'm just pointing towards what you said, that if we open, maybe just a dilatation and a final pot, if we want to be safe. That's.
I think what is interesting is to look at the data from COBIS 1 and 2, because you look at COBIS 1 and there is a deleterious effect of kissing. Then people have learned, they are following the rules. So the rules are short balloon at least for the side branch, non-compliant balloon in the side branch, asymmetric expansion of the two balloons, and deflation at the same time. So if you follow these rules, and it was followed in COBIS 2, then you have a beneficial effect of kissing, even when you have not a two-stent technique. So maybe COBIS 3 is different. Dr. Ku, maybe you may comment about that. So I think it's very interesting because even in the registry, the large registry presented by Bernard Chevalier this morning, he have shown that kissing had no effect, neither positive, neither negative. But 1 year before, with less patients, it was negative. So probably it's because people are learning to do a good kiss. I don't know, but it was negative, then it became neutral, and maybe in 2 or 3 years it will be positive. So we don't know. So maybe there is another comment in the room. Yes, Remo.
Yesterday in the complication case, you can find the slides on the web to see if you're not present. But there are 3 or 4 cases of, because now we have imaging. So you have a left main, no kissing, no opening, and then at the follow-up you see some haziness at the ostium of the circ. Now you go with your OCT, and then in 3 consecutive cases, there was no only 1 opening, but 2 or 3 openings. So there was a complete endothelialization, the area, and there was also a fractional fluorescent positive. So you have to do something, and what to do? When you have 3 holes, you have to open 1, and so to avoid this is, for simply this reason, I will open all my ostial circ because I want to avoid this problem.
And you want to have access to the distal part of this circ to treat a new lesion. But was it? I saw that. So I think it's very interesting because this neoendothelization of strut was observed before with the bioresorbable platforms. So it's very nice because you have pseudo-restenosis, which looks horrible, but which can be treated very easily because you just have to open the strut. Whatever the strut you take, of course, better to go distal, but you will solve the issue by just opening the strut, because the problem is that neonatalization of struts. So it's not restenosis, but it looks like restenosis.
You see, in the morning...
But you may destroy the stent if you do that. Huh?
Maybe. The cases which were showing in the morning, if I get corrected, that in the provisional stenting, when we are putting a crossover stent, some strut will definitely come in front of the ostium. Now the option with us is whether to leave the strut in middle or open it and put it in the side, and crump them in the side. If we crump them in the side, we are creating a bulk of the stents in the side, and maybe the epithelialization and all those things will come in. If it is in the center, it's likely to neovascularize and create 2 or 3 holes. But it was shown by him that it is always FFR not positive also after 1 year or 3 years also. So that may be just opening and putting all the struts which are finding in front of the side branch ostium, opening them and doing a kissing and putting them a lot of metal on the corner. I don't think it is required, because that is physiological. Some strut will definitely come in, no debate. But whether they are physiologically important or not, for that, I believe that rather than the ostium, I have to see the vessel distal to that, whether the vessel distal to that is diseased or not. If a vessel is distal to my side branch ostium, is heavily diseased or more diseased, I would love to open that. And if it is not diseased and the flow is good, I would like to leave it. So it is not a dictum that I should open it or not. And all these trials are not important, because we are talking about provisional. Provisional and an incidental stent in front of the side branch. It's not an obstructive stent.
Imad?
Yeah, I think we should, if we look on bench testing, we can stop discussion here. We should do it. But we are not dealing with bench. We are dealing with patient. Then our data, the data available today, should guide us what to do. What we have today, I think we do not need to take the risk to deform the stent just because I want to be comfortable, to feel comfortable to open the strut. Because many of the MACE coming in provisional stenting is coming from kissing balloon inflation. This is seen in every study. Because every time you are crossing the strut, you are deforming the stent. And if you are not going with intravascular imaging, you cannot be based only on angio. So I can understand you if you are using OCT or IVUS every time you are stenting, provisional stenting.
And stent enhancement is a very good surrogate for checking that you have done a good job. And of course, the technique is very important to learn how to do it well in the bench and in the patient. So if you are convinced that it's better in the bench, you should do it in the patient.
But no, but it is not absolutely what you have in really, I mean, in the real arena, in clinical. We all know that. And you are based on what you see on bench, but many times if you are guided by angio, I think it is very difficult to know where you are crossing. It depends on the stent. It depends on the stent design. Also, it depends on movement of the heart. Also, sometimes you cross, you think that you are crossing proximal, distally, and you are crossing in the middle, maybe.
But when if we start with a good view of the bifurcation, you see the carena, so you know where you should go, and you can go at this place. So then you don't know if you are close to a link or not, but you know that you are in the distal strut.
Yeah,
so I think this is a very small rules that are very important to do a good job, like you do in the bench. So you are doing DK crush.
We are all guided by bench testing. Yeah. We are all guided by.
So if you are convinced, you should try to reproduce the same in the patient.
In order to do like bench, I should go with IVUS or OCT every time I'm doing. That is the point. Second point, if I do not have any clinical benefit, why to do it? I mean, I'm not doing that for me. I'm doing for patient.
So last comment from Dr. Bhagwan.
Yeah, so there are two main issues. One is laminarity of flow, as we have seen studies are showing very clearly. Laminarity of flow with practically no shear affecting the carina and the adjacent segments, and ease of re-intervention. I think with these two factors in mind, I feel the struts have to be opened.
Can I say just one comment?
Yes.
So big remaining issue, big remaining thing we need to see. It's we need to check the clinical data. You know, if we leave the multiple sensor and the circumferential area, this is related to the restenosis, something like this. We need to check. This is, I think, remaining.
Actually. So do you think, Dr. Nakamura, do you think that it's time to do a randomized study? Because we don't know. 57% versus 56 versus 44. So it's very balanced.
A little bit more than the Brexit, but it's okay.
Okay. So thank you very much, and let's take time for a good coffee.